Okay, good afternoon, everybody. It's my pleasure to moderate this next session on operational women's health. And our first speaker is Dr. Katie Stout. Katie is Assistant Branch Chief, Traumatic Brain Injury Centre of Excellence with Research and Engineering at the Defence Health Agency. She has been in a variety of roles within the Department of Defence for 17 years. So over to you.
Good afternoon, everybody. Thank you so much for having me. I will try to keep this light and hopefully nobody dozes off after lunch. So I'll go through just a couple housekeeping slides. Got it. I did put my contact information up here. There are a couple of folks that I'd love to chat with after this. So if anybody's interested, there's my email. I'm also in Global here with DHA. The disclaimer, these are my views. They're not official policy of the DoD, and I have nothing to disclose from a conflict of interest perspective. We're going to talk today about the differences between men and women with TBI, what it looks like post-concussive symptoms. Primarily, we're going to talk concussion, and then a physiological difference between sex. So to dive right in, why gender differences? There's been a lot of questions. A lot has come up today in discussion, but at the end of the day, we don't exactly know why. Spoiler alert, more research is needed, and I'll get into what those needs are at the end of the talk. But there have been questions looking at menstrual cycle. Could there be an overlay of hormones? Could there be impact of the cervical spine, the musculature in the cervical spine? There was early data that looked promising, but again, larger scaled studies in humans have proven that that is not accurate right now. So maybe we're asking the wrong question. I did just want to point out when we talk about cervical spine, it was looked at the musculature, and I know there was a discussion earlier about the axial skeleton. I think that's a really interesting question to ask. And maybe we look both at skeleton and musculature development and impact of training. So there'll definitely be other discussions that we need to have offline. There is a Canadian company called Topspin 360 looking at cervical spine strengthening, not specific to concussion, but overall protection of the cervical spine, what that does for pain, and it could potentially prevent concussion. There's a study that just came out of the Canadian Armed Forces, so we had a call with them in late December and look forward to more collaboration. I talked about hormones a little bit. The preclinical data showed that progesterone improved TBI outcomes in an animal model from a neuroprotective standpoint, but then there were 2 large clinical trials in humans that did not have the same effect. We don't know why. It, again, showed promise in animals, but the translation to humans isn't there. So that is information that's still being looked at. We know time of reporting and also timing of the menstrual cycle is really hard to control for when we talk about research studies. So be on the lookout for that in your careers as you take care of women after concussive events. We know overall women have a lower incidence of TBI than men, and this is over the lifespan. So you'll see there on the far left, young children actually have a high incidence of traumatic brain injury across the spectrum of severity. It kind of falls off preteen years and then really ramps up late teens into early 20s. We know that's from risk-taking behavior. It is lower in women, but again, there's not a lot of evidence to say why. There's some hypotheses, but still more information needs to be determined. And this up here is information from the CDC across all severities. So what do we know? We did hear earlier that there may be challenges in translating information from our sports concussion population to our military population, but to date, that's the largest amount of data we have when we talk about concussion. So we do know that female athletes sustain more concussions per athlete exposure, but then the question is why? That may be answered in the next slide, but here, just looking at this data for a quick second, there is also variation within sport. And what does that also, how does that translate to variation across military occupation? So are there occupations that have higher risk? And we're starting to see that in the data, but again, not from a sex-specific breakdown. So I mentioned that there's a higher rate of concussion in female athletes, but there's also more reporting. So females are also more likely to report a concussion than men. And again, is that due to the type of injury? Is that due to some overlay of social context? We're not quite sure. But to date, there's more reporting from our women versus men. Again, just to highlight across, and this is across different populations, so from military service members to civilians in the emergency department to college athletes, there is higher reporting of symptoms. Again, why? We don't know. The topic of underreporting came up in a couple of the earlier morning talks. We know from a military standpoint, there is suspected underreporting of specifically concussion, but we can't really determine the volume of that because if you don't report, it's really difficult for us to measure. We did also, in some of the research coming out of the athletic populations, there's a longer return to play. So how does that equate to return to duty? Again, I'm presenting a lot of questions, but something to keep in mind as you're treating females after a concussion, there may be a little bit longer return to duty. But again, we don't have definitive data in our military populations to say that, but a consideration from a clinical decision making should be taken into account. Dr. McGraw had to leave. We're actually a sister center of the Psychological Health Center of Excellence, but depression after TBI, again, there doesn't appear to be a gender difference. In fact, the more moderate to severe populations where there's much more data on traumatic brain injury, there was no difference a year after injury on depression rates, but there may be variation across the recovery, and it's something, again, clinically, we don't have a definitive aha that this is the better way to treat male versus female, but just something to keep in your clinical consideration decision box. We did talk earlier this morning about military sexual trauma and what that means. There is a higher reported rate of intimate partner violence and PTSD in female service members, and that is related also to traumatic brain injury. I would encourage those clinicians in the room, if you're taking care of women, to ask those questions about head injury if there is a case of sexual trauma or interpartner violence. When we did some data capture of TBI across military clinics, there was actually a capture of TBI diagnosed in the OBGYN clinics, and that was really promising to see that those questions are being asked. It is thankfully a small number, but it is a question that needs to be asked when you're treating patients in all clinics. So the take-home messages, I kind of gave the bottom line up front when we started, but in general, there are fewer concussions amongst females. There are different mechanisms and cause of injury. And again, we don't know from a TBI at large perspective, we don't understand all of the different mechanisms and what that overlay looks like. In fact, some of my colleagues are at NIH today to talk about biomarkers and some of the future science as we look at concussion and how to best diagnose. To date, we don't have a biomarker for concussion. So without a objective biomarker, right now we have a point of injury and we have symptom reporting. And that's really difficult and overlays a bunch of other variables that make it very difficult to control for. Interpartner violence should be considered, TBI should be considered when you're talking about interpartner violence, making sure that those patients are appropriately screened because it can often go missed as other more severe topics are being addressed. And again, as I mentioned at the beginning, biomechanics and hormones may play a role, but much more research is needed in that area. So the way forward, more objective data sources. We talked earlier about data sharing. I think there might be a value of data sharing across groups and researchers when you're talking musculoskeletal to neurological research, is their ability to bring those research information together to help complete the picture of what it might mean for TBI and sex differences. We did see in some of the research that there's difference in symptom reporting and symptom reporting patterns across male versus female, but to date there's no aha that this is the symptom pattern that a female would present with versus a male. There's still variation. So again, a lot more work needs to be done to close that gap. more stratification of cohorts with male versus female and better representation of females in our cohort data. So we heard also there's been change to military policy over the last 10 years that's opened up the aperture for women. So there's a lot less historical data for women in some of the more intense MOSs. And so having that historical data will certainly help. There is a 15-year longitudinal study that Traumatic Brain Injury Center of Excellence is lead for, working collaboratively with the NICO and some of the other military treatment facilities within the DoD system, looking at exactly that 15-year longitudinal data of our service members. And even within that cohort, females make up a very small number of that information. So within the larger context of concussion, we still have answers or questions to answer, and more specifically for our women, what does that mean for them over their military career? With that, there's a bunch of references. If folks have questions, I'm free at the Q&A and also via email after. So
our next speaker is Dr. Tara Riley, who's presenting on musculoskeletal injury prevention in the Canadian Armed Forces. Tara is a research officer in the Canadian Armed Forces. She completed her BSc and MSc from, I want to say, Dalhousie, but I might have got that wrong, at university, and her PhD from the University of Portsmouth in the UK. Tara has been working with the Canadian Armed Forces for the past 15 years, focusing specifically on physical employment standards and physical training, and of late in female populations.
Thank you. And I can say, I'll up the ante. I have one contact lens and glasses. So that's the most help anyone so far up here has used. So as Julie mentioned, I'll be discussing evidence-based programs for musculoskeletal injury prevention in the CAF, supported by research. So this is actually my older presentation. That's okay. So about 4 years ago, before COVID, I was asked to kind of put together a portfolio of what I had been working on with regards to women's health and readiness in the CAF. And that was about the time where we finished a NATO working group and RTG, Human Factors Medicine, which Julie was a part of, 10 countries with 23 members. And it was to answer questions regarding combat integration, which the US and the UK and Australia were endeavoring upon, and physical performance. I was also working on some thermal physiology projects with the Army, considering women and FFO and heat tolerance, and then collaborating here with USARIUM on bias and physical selection tests. With the UK, we did some projects on CAF performing urban operations exercise. There's a couple of publications there on sex differences in neuromuscular fatigue and factors affecting and predicting performance on operations. And then Australia, there's a review paper, if you're interested, on male and female data and musculoskeletal injury prevention in physical demanding roles, military roles. And the spoiler is basically fitness negates sex often for the risk of musculoskeletal injury. We're always looking for these what risk factors for musculoskeletal injury, but if fitness levels are basically not equivalent, but high enough, then the gender difference is nullified. So the NATO group wrapped up in 2020, and that publication is available online. And our kind of final moving forward was to join a TTCP and do more research on the application of prenatal and postpartum training programs, and also considerations for military during pregnancy. And this was the model that we developed based on kind of the readying for deployment model, looking at pregnancy and maternity leave as, you know, when you're pregnant, you need to adapt and protect. And then in Canada, you can take up to 18 months leave. So that's when you have to start thinking about maybe 2 months after delivery, strengthening pelvic floor, all these other things that we need to do some checkpoints on. And Julie's group is doing some amazing research in that area. And then back to your occupational demands, back to your physical employment standard. The reason that we are focused on musculoskeletal injury in the Canadian Armed Forces in terms of recruiting and retaining women is that it seems to be one of the, or if not the biggest reason for medical release. There's a report from data in 2014 to 2017 which would indicate that CAF women have a higher percentage of medical release than men at earlier points in their career. With a caveat that a recent publication from Australia, which did a meta-analysis on male and female military personnel injury data, reminds us that women are more likely to report an injury, and these injuries are more pronounced at basic military qualification. After that, these gender differences might not be there anymore, because based on the workloads, you're more able to self-determine your own workload, you're able to exercise at your own intensity, and maybe the occupation that a woman selects could be less physically arduous, maybe it's not a combat role. Again, they indicate that the difference in fitness should be more considered than the difference in sex. Some of our existing musculoskeletal injury prevention initiatives are similar to what Julie presented with their basic military qualification. We're using the same device, the Genie Active, to measure sleep and accelerometry over the basic military BMQ, the basic military qualification course. And looking back at our injury data from 449 injured recruits, our physical employment standard, one of which the components is a drag of a load, is able to predict injuries quite well. In fact, if you aren't capable of doing that drag, a female is 4 times more likely to be injured during the BMQ course of what was, I think, 10 weeks and now is coming down to 8 weeks. And for males, it's the same, 5 times more likely if they can't complete the drag. So should we be suggesting decreasing the completion time of this physical selection test? Well, I don't think that's a very popular thing to suggest, but in this particular fitness standard, we are able to predict, I guess, ratios or relevance of injury during BMQ. We're also, so part of the reason that that's so interesting is that we can also now have pre-BMQ training programs to require applicants or to help applicants pre-train before they reach basic military qualification. Another piece of work which falls in line with the researcher that just presented is I'm involved in the aircrew conditioning program, which is also to reduce MSKI in males and females, looking at neck strengthening and reducing injuries for aircrew. And then we do something called the GRIT injury prevention training at Meaford, which is our DP1 infantry. So that's developmental period 1. After BMQ, the infantry go there. And we've had, what Julie also mentioned is useful. We've had experimental and control groups. So the control group receives physical training by the course instructor, and we're not involved. And then the experimental group receives training by a certified exercise physiologist with a degree in kinesiology. And those training programs are designed based on a lot of the work that Brad Nindle and other groups in the US and UK have developed lower body strength and conditioning programs, because that's where the overuse injuries are often happening. So those training programs look very different. And the evidence-based training programs have reduced injuries in 3 courses over the past 3 years, 58%, with 371 fewer medical employment days. So we're now rolling that out with the Army, with the troop commander, the artillery troop commanders course, which has 25% women, and also with the Canadian Forces Health Services College, and that is, I think, the medics we're working with now are 70% women. So we'll have more exposure and more research on women and using these evidence-based training programs to reduce injury. We put together a holistic plan looking for female-specific programs and prevention throughout the whole career. So Major General Bilodeau just discussed this morning the journey, and this is looking at one's whole career. And so our CMP, our Chief of Military Personnel, asked us to consider the whole career when looking at musculoskeletal injury prevention. So preparation for occupational and operational training, but then also career interruptions like prenatal, postpartum, and then maintaining function through age. And this is our plan that we proposed and was accepted and approved and funded with consultation from Colonel Helen Wright, who is here today. And you can see how we've divided a military woman's career journey from the start of recruitment right to retiring. I'm personally interested right now in kind of menopause and if exercise can have positive influences on coping with menopause. A lot of our efforts are in prenatal postpartum phase. and we are doing pre-training for pre-recruitment to prevent injuries. Some of the metrics we'll use are listed here: rates of injuries, compliance on the physical employment standard, participation in the activities, percentage of medical releases, length of career, things like that. And then this diagram describes where across Canada in our bases and wings we find the women who are taking a maternity leave the most. The average is 114 women per year. And from these data, we then hired 12 professionals, fitness professionals, who will go and deliver prenatal postpartum training programs at these top 12 bases or wings that have the most women who are on maternity leave or likely to take maternity leave. So those programs will be delivered by clinical exercise physiologists, and we'll also have virtual programs for those which only have 3 or 4 women. Just a quick review of what's available for prenatal postpartum training programs. There's P3T, I think, here in the US. Perform is the one that Julie's team is researching. And then NEPI is European. And in Canada, we have something called the Canadian Society of Exercise Physiology, which has a really great prenatal and postpartum training program. And we're all basically focused on the same thing, which is pelvic floor, all these risk factors, and how to incorporate health services with our physical training specialists. We have lots of great SMEs. We have Commander Casey Campbell, who's helping us look at considerations that are unique to military women, also exemptions from duty of service when pregnant, and then when you come back to work, you'll have 12 weeks to meet the physical employment standard, the force evaluation. That needs to be clarified, as well as when does the health services refer to the physical training specialist for increasing or changing the physical training program. And just quickly, this is Julie's work, and I can't wait for it to finish up, and we can see what we've learned from her. But she's doing a clinical trial on her postnatal training program, and they're measuring pelvic floor strength with a pelvic health physiotherapist. Similar type programming that we are using to prevent injury, looking at more strength and endurance than specifically weight loss or aerobic. And then they have their physical employment standard as one of the metrics that they're using to determine the effectiveness. So we'll glean a lot from this, and we'll apply it to Canada. And lastly, these are just examples of our prenatal postpartum programs that are currently operating. One at CFB Kingston and one at CFB Valcartier, when they include military and civilian, and they're operating 3 days a week. And babies are coming into the gym and helping moms stay active throughout their maternity leave.
It's really great just to see where we can really have mutual collaboration between these studies. So we next welcome Lieutenant Colonel Jessica Lottridge, who's going to speak on optimizing women's health in cadets. Jessica is a family and prevention medicine physician and is currently the Chief of Prevention Medicine in the Cadet Clinic at the US Air Force Academy.
Thank you, and thank you for having me here today. So today I will be reviewing pertinent issues regarding women's health in the cadet trainee environment. Right, I have no disclosures, and this is a summary of what I will be discussing. So women now comprise about 1/3 of a service academy class. The service academies have a unique curriculum on the pillars of military training, academics, athletics, and character development, all with the goal of giving cadets and midshipmen the skills and knowledge to succeed as an officer. Cadets are challenged both mentally and physically. Military training begins with basic cadet training and continues throughout the year within their academic squadrons. There are various programs cadets participate in during the summer, to include survival training, airmanship programs, and basic cadet training cadre. There are also airmanship opportunities during the academic year. All these courses offer opportunities for leadership. The academic curriculum is rigorous with many required core courses. All cadets are required to take fitness tests as well as physical education classes, which include things like combatives and water survival. All cadets also participate in competitive sports, whether it be intercollegiate athletics, club sports, or intramurals. Throughout the pillars is a focus on character development and leadership. It's a rigorous 4 years and it's easy to get behind. To add to the challenge, cadets must meet accession and retention medical standards for all 4 years. So for your perspective, above is a summary of the services available at the 10th Medical Group. So the 10th Medical Group is considered an outpatient surgical center, and the Cadet Clinic, which is located within the Cadet area. We have cadet medicine comprised of primary care, sports medicine, adolescent medicine, preventive medicine, and immunizations. Also located in the clinic are flight medicine, dental, physical therapy, and optometry. Pharmacy and lab have outlets in the clinic, and radiology offers plain films. In the main medical group a few miles away, we have quite a few subspecialties, as well as a more robust radiology services. Several specialists come over to see patients in cadet medicine throughout the week. This currently includes orthopedics, derm, cardiology, and ENT. And mental health services are available in the cadet area and at the base community center. So as we've just heard about, female trainees have been shown to be at higher risk of bone stress and overuse injuries, in particular of the lower extremities. Known risk factors for these injuries include low aerobic fitness, low overall physical activity level prior to training, short stature, low body mass, previous injury, and menstrual irregularities. Entering training with a high level of aerobic fitness and participating in regular strength training can help prevent injuries, as can addressing menstrual irregularities. If the cadet cannot heal quickly, these could be injuries that delay training, or perhaps cause them to have to depart and go on turnback. Turnback is where a cadet chooses to leave temporarily to heal. These injuries could result in a medical board and no longer meeting accession or retention standards. At USAFA, a lot of work has gone into preventing injuries. So all appointees are given a handbook. This handbook provides a graded exercise plan to prepare appointees for basic training. The athletic department and physical therapy work to build this plan. Training is also graded upon arrival. This allows time for sickle cell trait screening, as well as altitude acclimation. PT also checks running shoes on I-Day and tags shoes that need to be replaced. So the female athlete triad, or functional hypothalamic amenorrhea, is not uncommon in college athletes as well as military females. Eating disorders are also prevalent among college students in general and likely underreported. Eating disorders are also likely underreported in the military. The three components of the female athlete triad are low energy availability due to either disordered eating or a lack of nutrition relative to caloric expenditure, menstrual dysfunction, and low bone mineral density. Precipitating factors include increases in exercise, low weight, and stress. Consequences of the female athlete triad include increased risk of stress and overuse injury, and ovulatory infertility, and sexual dysfunction and genitourinary symptoms. Treatment includes weight gain, ensuring adequate caloric intake for energy expenditure, and decreasing stress. At USAFA, we have a multidisciplinary team to treat these patients. That includes adolescent physicians, nutrition, sports medicine, and mental health. We have a low index of suspicion for identifying at-risk females. An example is our universal anemia screening. I'll discuss that screening in more detail later, but when we see those patients for additional evaluation, we pay particular attention to their body habitus and their BMI. So abnormal uterine bleeding and dysmenorrhea are common problems with a variety of causes, from uterine to non-uterine. Abnormal periods can have a variety of impacts on training. For one, it can be inconvenient, but it can also limit the cadet's ability to participate in training. Heavy bleeding in particular can lead to anemia. Anemia has been linked to musculoskeletal overuse injuries, degraded physical and cognitive performance, impaired immune function, and depressed mood, as well as overall worse training outcomes. Treating anemia may improve performance and retention of trainees. Before cadets have acclimated to altitude, anemia can contribute to poor performance. At USAFA, we provide full-scope primary care along with subspecialty women's health that is equipped to address all of these problems. We screen all cadets for anemia on in-processing day. All cadets with abnormal labs are seen for a face-to-face evaluation. We offer iron replacement and also evaluate for other causes of anemia if indicated. We also offer contraception for management if indicated. So nearly all female cadets are 21 by the time they graduate, and most will have their first pap smear while at USAFA. MH Genesis, our new electronic medical record, has made it challenging to pull overdue lists. but we do catch most due cadets at their graduation physical, which is done their junior and senior year. We do perform pap smears in cadet medicine. Our women's health clinic also often comes down to help us out. Women's health also manages all the abnormal paps. I recommend attempting to have female providers in the trainee environment. This is not just for patient comfort, but also to expose cadets to female medical providers. All cadets are also in the recommended age range for HPV vaccination. Several years ago, a robust process improvement project and vaccine campaign was completed by a few of the people in this room, I think. Cadet medicine worked with allergy immunizations to add the HPV vaccine to the Cadet Med immunizations program. An HPV module was also added to ASIMS, that's our readiness module for tracking. This is one of the many areas where we fell behind during COVID, but you can see above the cadet vaccination rates compared to the US. So we're a bit lower than the national average for teenagers. So 1 in 5 people in the US have an STI, and almost half of new STIs were among those aged 15 to 24. So young women face serious long-term health consequences from STIs to include infertility. Most female cadets are in the age range for annual chlamydia screening. You can see above the gonorrhea and chlamydia military incidents over the past decade, as well as our rates in the cadet wing. Our rates are lower than the military in general and have been declining over the past few years. We screen all cadets during basic training as well as during the graduation physical. HIV screening is accomplished on in-processing day and at the graduation physical. We do offer pre-exposure prophylaxis for HIV. The USPSTF now recommends hepatitis C screening for all adults, and we will start screening for hepatitis C on this upcoming in-processing day with the class of 2027. Other STI screening is done when indicated, and we do have a walk-in STI clinic. And the support staff protocol that we use is now used by all the primary care clinics at USAFA. So cadets desire contraception for many reasons, to include birth control, regulation of menses, and acne treatment, to name a few. On the slide are stats on contraception prescriptions in the US versus the military, as well as utilization by the cadet wing. Overall, contraception use has declined over the past couple of years, with the majority of cadets opting for short-acting contraception. Emergency contraception prescriptions have remained relatively stable. Use of contraception can decrease missed training days due to abnormal periods. Cadets who become pregnant face several challenges. They no longer have to give up parental rights, but they cannot have a dependent while a cadet, so they must have a plan for someone else to care for their child. Pregnant cadets also usually end up going on turnback, which delays their graduation and accession into the Air Force. USAFA offers a wide variety of contraceptives in cadet medicine. Access to care is usually same day, and we do offer a walk-in contraception clinic in the mornings. And here are my references, and I'm happy to take any questions at the end of the panel. Thank you.
And our last speaker on this panel is Lieutenant Colonel Leslie Boiter, who is an emergency physician currently serving at as the Associate Chair for Education in the Department of Military and Emergency Medicine at the Uniformed Services University. Over to you, Leslie.
Good afternoon, everyone. It's nice to be here and talk with you today. We're going to change gears just a little bit, and I want to talk about the women who are on deployment and those who might experience a combat injury. We spend a lot of time at USU and in the Department of Military and Emergency Medicine preparing our students to practice tactical combat casualty care. And we started to wonder, can they perform these skills on female patients as well as male? I need to go through a few disclaimers. These are my opinions, not those of USU or the Department of Defense. I am going to talk about a few specific products that are not being endorsed by any of us, and our research was approved by the IRB. So the first question is, what do we know? We know, as other speakers have talked about, we have an increasing population of females in the military. We know that more females are in the far forward occupations and could experience a combat injury. We know that our future operational environment is really uncertain, and we don't know what we're facing next. And we also know that all service members in the U.S. are required to be certified in tactical combat casualty care. So then we start looking at the literature and what's out there. And the bad news is there's not much. Part of that is from a couple different reasons. We do know that females experience trauma at a lower rate than males. I think one of the prior speakers talked about different risk-taking behavior. There's been a couple attempts to try and quantify, is there a difference in care provided to female versus male patients? This is a retrospective study that came out of Sweden that showed that males were given a higher pre-hospital priority than females when they were picked up by ambulance for similar injuries, but they didn't find any outcome difference despite that change in priority. Another study that looked at about 20,000 trauma patients saw that TXA was given at a higher rate to males instead of females. Males received it about 17% of the time, females about 7%. And so that might be clinically significant. We're still not sure. Now looking at DoD literature, military trauma literature, we have a 2011 study that looked at what was then the Joint Trauma Theater Registry and found that females made up about 2% of casualties, 1.9%, but they were 2.4% of the deaths. So again, very small number of female patients, so it's hard to know what that means. Another study came out in 2018 that looked again at the DoD Trauma Registry. There was about 19,000 males in the registry and 500 females, so numbers are different, and they tried to match them based on injury pattern and found comparable survival rates, but the females were less likely to receive pain medications, which was interesting and doesn't really make sense yet. So we look at some work done by the Israelis, and they tried to determine, is there a gender difference in providing analgesia in the military setting? And they didn't find any evidence of that. No correlation between gender and oligoanalgesia, and no bias depending on who the healthcare provider was. So this led to my research team and I trying to decide, is there a problem and do we need to address this? So our question, is there a difference in TCCC that's provided to male versus female patients? So we talked with some colleagues who ran a pilot study. The study had 10 participants who were actually all Army cadets. They had very basic levels of TCCC training, and they treated 2 casualties, 1 male mannequin, 1 female mannequin, and they found that there was a lower success rate on the female mannequin regardless of what order they took care of the casualties. There's an expected training curve where you get better with the second patient that you treat. But in spite of that, they couldn't find that they treated the female casualty with the same success. So we proposed and were approved to run our own study at USU. Our participants are TCCC trained medical students and enlisted medics that are in the local area. And we wanted each participant to take care of 2 patients, 1 female, 1 male, in a random order. We video recorded the patient encounters so that we could check for quality later on, and we could also time how long it took to perform each step in the care. And then afterwards, they participated in something called a Think Aloud, which was a new concept to me to learn about. This is a structured interview where you prompt the participant to watch the video of what they're doing and then narrate the entire thing. So the goal was to not just figure out, does this happen, but why does this happen? If there's a delay in care for the female patients, why? So we brought our participants in and they took care of a male or a female patient in different orders. And one of our hypotheses as we were going in is, could there be a difference in treating an inguinal wound, a groin wound, in a male versus a female patient? So they took care of 1 patient with chest trauma, 1 patient with a groin wound, and then we determined if there was any difference. We used a device designed by Symmetry, which is a company. They call it the Gender Retrofit Kit. And what this is a chest overlay genitalia and a wig that you use on a standard Laerdal Simman 3G, which is the high fidelity mannequin that we find pretty commonly in hospital-based simulation centers in the US. And this is a picture of one of my research assistants helping us. This is the female mannequin. You can see she has her uniform on that can be removed. She has moulage injuries that are on the left side of her body, so it's hard to see. And then we did put a bra on the mannequin, as we would expect a female service member might be wearing. So we looked at the demographics of our participants. We wanted to make sure they were fairly equal. And we had about equal number of male and female participants. And for their background, they come from a wide variety of experience before they either matriculated to medical school or came to work on staff with us at USU. There are about a quarter of them have a military medic background. Some others have pre-hospital care experience in the civilian world. And about 20% of them have actually treated a patient with a combat injury, which we thought might be interesting, and we were unsure how that was going to play out for us. So we look at our results, and we're still analyzing, particularly our qualitative data. That's taken a while. And for our quantitative analysis, what we found, as expected, is that there was faster care on the second scenario compared to the first. And that makes sense. And it didn't matter what order they took care of the patients or the gender of the participant. So that was good news. On our early qualitative results, we saw some emerging themes that the participants developed confidence in the March algorithm of tactical combat casualty care as they dealt with the massive hemorrhage, the airway, the respiratory problems. So they displayed more confidence on the second scenario versus the first. They were uncertain in caring for the mannequin regardless of the mannequin gender. So maybe there was confusion about our training tool. And they were uncertain in disrobing the female mannequin to assess for the chest wound. So we went back and looked at that again. And there were 13 participants who cared for the female patient that had a penetrating chest wound. 3 of the patients did not fully disrobe the patient. Those 3 patients did not find the chest wound injury. And the scenario was that there was a blast and that you had a single patient to care for. And if you haven't worked with a high fidelity mannequin, you can control their respirations. So this patient only had unilateral rise and fall of her chest. So they should have been able to pick up that there was a chest injury. So 3 people didn't even find the wound. 1 person delayed the exposure of the wound and eventually found it, but they went and did some other activities of the TCCC algorithm first before they came back to it. And 1 participant placed the chest seal over the clothing, over the bra. They thought there was an injury, and then they pulled the bra back down and put the chest seal on top, which would make it ineffective, and it wouldn't work. So we had a lot of questions, and we still have a lot of questions. And number 1 is this simulation adequate? We have pretty strong literature that shows medical simulation demonstrates how someone will perform in a real-life setting. We want to know, is the mannequin realistic? And the company who provided the gender retrofit kit has done some research on that, and they're trying to prove that this is a realistic example of female anatomy. Does training performance compare with real-life actions? Again, we think so. It's pretty hard for us to prove. And we want to know, are the participants uncomfortable exposing the female patient's breast? And our qualitative information doesn't compare with that. Of the 3 who never disrobed the patient, none of them commented on it in their post-encounter think aloud. So they didn't even recognize. 2 of them came up to me later. My carrot of getting them to participate was to say, I'll answer any questions you have when you're done with the study so we can talk through medical care so they could get better at providing medical care. 2 of the participants came and asked me, I don't understand why my patient wasn't getting better. And so we went back and looked and I said, well, did you see this? Nope, never saw that. So they didn't have any insight to the fact that there was a missed injury. So what do we do with that? There's a lot of continued questions. Our research team has some goals to perform an observational study at an upcoming TCCC course that we'll have this summer. And what we want to do is create an intervention that reviews for all patients, how do we disrobe and appropriately find injuries? Because perhaps there's a disconnect there. Again, it doesn't have to do with the fact that it's a female versus a male. There just happens to be an extra layer of clothing that they haven't practiced participating in. And we want to encourage all operational medical units to completely simulate medical care as they're practicing it. And that includes having female simulators, disrobing the female simulators, and finding the injuries if they need to. Thank you.
Okay, if I could invite all the presenters up to take a seat at the front, and we'll take both virtual and in-room questions. First, I'd like to thank you for being really disciplined with your time of your presentations. Superb. We're going to go straight to a virtual question.
All right, so there's 2 questions that I will make into just one. So it is for Dr. Riley. When you say the difference between the sexes with respect to MSK injury is nullified when fitness is high enough, what exactly is high enough? What is the metric? Is it relative versus absolute? Strength, power? That would be the first question. And the follow-up by Dr. Karen Breek would be, is it valid throughout all aspects of a woman's life cycle, i.e. pregnancy, postpartum, menopausal?
Okay, I can only answer that from the Canadian Armed Forces perspective, is that we looked at one standard deviation, multiple standard deviations away from the norm of and the minimum standard of our physical employment standard, and it was really down at the lower kind of 3 to 5% where we saw the most significance in injury prediction. So it's definitely not a high level of fitness for our physical employment standard to predict injury. It's more those who are just passing, not passing, or in the lower 5%. And that went for the males as well. I know that the UK has looked at correlations between aerobic fitness and injury and have found that for specifically injury during rock marching, higher aerobic fitness is preventative for injury and also negating the gender difference. And I think lean body mass is also a better predictor than sex. So I would just say before we go and dichotomize any musculoskeletal injury data by gender, I would look at, or sex, I would look at other things that we know that are modifiable and can be used to and modify those things to prevent musculoskeletal injury. With regards to the entire journey of a woman, I believe that the research indicates that we have to take special attention to, proper rehabilitation in the postpartum period, and that will again depend on the occupation that the woman is going into when they return to work. Is it arduous, and what's expected of them right off? And then mostly I'm concerned with how do we work with health services and physiotherapy in what assessments do we do, whether they're pelvic floor health or functional assessments in, okay, now we can enhance the intensity of the program, because there's definitely safety measures we have to take to ensure that when a woman comes back from their postpartum period, that they are in the best possible place to prevent an injury. I'm not sure about menopause. That's an area where I will need to read more, and I was thinking of actually, perhaps there's enough energy and interest in a NATO RTG again on that one, because it's definitely a research topic that's under researched, and probably one of the reasons is that when you don't have countries that have had women in combat roles, there's less women, over 45 in the military to have and use as research participants. So Canada, again, I think we have a nice population of women compared to other countries, especially in those age groups. So hopefully we can do some research in that area.
Thank you. We'll take our next question from the mic.
Hi, Leslie. No, it's Steve Lanzo, UK Meadowlow from the accent. I just want to say thank you, because I think it highlights the importance of a diversity in the simulation models that are available. We can get really high definition canine models, but we can't represent 50% of our population realistically. Going to the actual study itself, I was just wondering if they had combat body armor on as well, because again, just that extra layer, I think people are just not happy taking extra layers off, and so there's the technicalities, ironically with the bra perhaps, about where to cut, particularly with wiring. And then one thought, and I don't know whether it's ethically allowed, would be whether you could reproduce that study again, possibly using live actors, obviously in the correct framework and everything as well. But certainly in the UK, we've just been doing a big education piece about correct placement of defibrillator paddles on a female body as well. So I think very relevant. Thank you.
Your question about body armor, no, the mannequins were not wearing body armor. And later, when I thought about it, they also didn't have undershirts on. And so the male patients didn't have an extra layer to go through. So this summer, when we're running our TCCC course on campus, my goal is to have a lot of t-shirts and remind the participants, cut everything. If you think you need to cut, you should cut. As far as the ethics of doing it on a real people instead of mannequins, I'm not sure about that. One of the participants did suggest that the reason they didn't disrobe is because that was never part of their medical training. They would never disrobe a classmate who they were practicing on. So I think there's some training issues there, rather than individuals who are biased against women and don't want to take care of their female service members. They just haven't practiced those steps. So we'll see, but you can help us this summer if you want.
Very happy, although I won't be volunteering as a live model. So thank you.
Okay, virtual question at the back.
Yes, so this is a question from Genevieve. Has any research been done on pelvic floor injury post-childbirth that gets exacerbated by the current calf force test? This was asked during Dr. Riley's presentation?
I'm very interested in the answer to that question as well. I don't think we have the ability to investigate our health services data to that finite level at the moment. We are looking into, or I know that some CAF members are looking into or requesting information on injury during the force evaluation. One thing I would say is, our physical employment standard is about a cumulative of 7 minutes long. And if you haven't physically prepared for it, you're more likely to get injured on it. So you're not likely to get a repetitive stress injury on a test that lasts about 7 minutes. But if it's the first and physical thing you've done in a year, then you could end up with a strained muscle, and that would go with, I'm assuming, pelvic floor as well. So I don't have the answer to your question, but I think if we apply proper postnatal training programs with physio oversight, health services oversight, that's much more unlikely to happen than without. And that's basically what I'm trying to achieve. So, or what we are trying to achieve with health services.
If I could just follow up as well, we published data last year in BMJ Mental Health where we looked at the rates of musculoskeletal injuries pre and postpartum, and pelvic floor injuries certainly didn't kind of fall out of the injury data that we assessed. I guess one of the key risks there is more urinary incontinence and those kind of issues postpartum. Okay, I think.
Yeah, that question just made me smile. The Army changed their PT test the week I came back from maternity leave. But anywho, I'm Kylie Hugler. I'm one of the chief residents in gynecologic surgery and obstetrics at Walter Reed. Thank you so much. My question's for Lieutenant Colonel Lottridge. One thing that we found pretty fascinating was the data about there was over 1,000 prescriptions for OCPs amongst the cadets and only something less than 100 for long-acting reversible contraception. And this is a population that obviously has access to any LARC they desire and has a lot of benefits to that. I just was wondering if you could comment on why you think that is and if you think we can overcome that with more education.
Yeah, no, that's a great question. And when I look, I think on my slide, I think I just had this past year's data. We have a trainee health council once a month, and we actually just were reporting that data this past month, where I was looking at the past quite a few years. And a couple years ago, we had a big spike in the use of LARCs. And then, everything just kind of went down and that trend reversed a little bit. I don't have a specific answer why. We haven't done any studies to, ask cadets, what are the reasons for their preferences and things like that, or at least while I've been there. But I do think there's a trend in a lot of our things like cancer screening, vaccination, kind of long-acting contraception. And I think a common trend might be COVID. A whole side conversation is kind of everything that we managed with COVID within the cadet wing, and it was pretty time consuming. I know there's some people here who were at USAFA during kind of the dark days of 2020, and really a lot of preventive care kind of slipped off because everybody was just so task saturated with managing COVID. And I think we really need to get back into educating our population. Trying to get people in to get their HPV vaccine, talking about LARCs, really making sure everybody's understanding the risks and benefits of the different types of contraception.
So a question that arose during Lieutenant Colonel Lottridge presentation is a question from Lydia regarding contraception. Do you advise on what contraception will work best for different deployments? We know that different contraceptives have different adverse symptoms for different people.
Yeah, that's a good question, and I think that might have been alluded to a little bit earlier. I know with the Decide and Be Ready app. I'm sorry if I said the name of the app wrong, but I think some of that might have been in that app as well. I think it's two-sided. I think some of it depends on what the patient wants. We can make assumptions that maybe somebody doesn't want to have a period depending on where they're going. So maybe a LARC would be better, or taking continuous, OCPs so they're not having a period while they're deployed. But then certainly there's some personal preference with that as well. And then, in some environments, there was always, like the Newvering in particular had issues with refrigeration and things like that that might need to be a consideration depending on where somebody's going.
Hello, this is Lieutenant Commander Wallace. So it's a TBI related question. So, barring there being a specific blood test to have objective data on specific TBI signs and symptoms, have you seen any correlation with differences in ANAM scores as a more objective measure between the genders?
It's actually a great question. I don't know the answer if there has been. I can tell the group that the ANAM DOTI, the 649013, is currently under revision with all the Warfighter Brain Health initiatives, and it's going to move to an over the life of the service member monitoring, not just a pre and post deployment. For our colleagues outside of the US, the ANAM is our neurocognitive assessment tool. So I was actually just talking with some folks, could we look at that data over, moving forward over the life of our service members to also look to see if there are gender differences. So we don't have it yet, but maybe.
Thank you.
Yep.
Actually, Dr. Stout, whilst you've got the microphone, quick question on MTBI from me, if I may. You've mentioned, obviously, the potential influence of sex hormones on MTBI risk. Do you think that could potentially be more behavioural, with women being more risk-averse potentially across the cycle, rather than a direct influence of the ovarian hormones on MTBI risk?
That's come up in discussion. The other piece is the risk-taking behavior. There's just a lower risk-taking behavior across all populations, not just our military women. So that may also play a role. But we also know the numbers are very disparate. We have much larger population numbers of male versus female, so there does need to be control of that. Two efforts outside of concussion are also the long-term effects of TBI and blast exposure over the life of a service member. And there's budding work to look at that and what that means across gender and sex difference.
So do those data pull out those on contraceptives and not, as well as across the menstrual cycle?
Say that again.
So do the data also disaggregate the contraceptive data from the endogenous hormones?
No. It was more, so the progesterone study was looking at the injection of progesterone as a neuroprotection after injury in the emergency department. It was actually work done up at University of Rochester, I believe. So I'd love to talk to you more afterwards.
Thank you very much. Yep, fascinating. Do we have a virtual question?
Yes. So again, another question during Lieutenant Colonel Lottridge's presentation. We know that military women are more prone to service-related urinary stress incontinence and pelvic floor prolapses unrelated to pregnancy. Is there any thought to encouraging pelvic floor strengthening programs to be made available for all women immediately on enrollment versus only making these sex-specific training resources available if/when pregnant?
That's a good question, and I will be honest that I don't really have a good answer off the top of my head for that. I will say I don't know that we've seen that a lot, at least at USAFA in the cadet clinic, but I can't really I can't say that with accuracy. I would have to go back and kind of run and look at diagnoses that we have in the clinic. Just off the top of my head, I don't think it hasn't been a very common problem. But I think that's a good question, interesting question. I may actually defer to Dr. Riley if you happen to have anything to add.
I believe that males have a pelvic floor as well. So I would say everyone should be doing some pelvic floor exercise. And I'm not making a joke. I mean, this is something that any exercise physiologist would encourage, just like these kinds of things become trends as well. We were really interested in transverse abdominis and your core training, and it's all important to consciously engage. So I think as training evolves, it's up to the military to catch up to that and figure out how do we encourage exercises that engage the pelvic floor for males and females.
Can I just possibly follow up on that? Because interestingly, there's a high prevalence of urinary incontinence in athletes who have got a very kind of toned pelvic floor. So it seems to be like it's a hypertonic pelvic floor. So it's the breathing patterns with the pelvic floor seems to be the issue. So I think this misconception potentially, maybe not the postpartum space, but certainly with those who haven't just had a baby. It's overdoing it on the Pilates and yoga to try and strengthen pelvic floor could not necessarily have a favourable effect. But I think we need to really learn more about this. Any more questions?
So a question that arose during Lieutenant Colonel Volta presentation from Commander Casey Campbell. We're talking about the findings of possible differential treatment of men versus women in trauma care. Should this information be disclosed to women deploying? And if so, how do we remain ethical with these initial findings without negatively affecting women?
Yeah, that's an interesting question. So it sounds like she's asking, should we disclose to female service members that they might get substandard care? As a female service member, I find that unacceptable. And as an educator, my role is to ensure that there is no difference. And so I think instead we focus on how do we train appropriately and prepare all of our service members who practice TCCC to take care of all types of patients and make sure that they're meeting the same high standard.
Really great discussion. Just one final question then from the mic.
Yes, ma'am. Actually, I just wanted to circle back on the pelvic floor health issue and discussion that you were having. Roughly, we believe that the lifetime experience of women is about 1 in 4. And when we looked at studies that we've done, one of our challenges is it was done with claims data. And so it doesn't take into account all of those patients who didn't report or it didn't get diagnosed and it didn't get treated. So we are working in our efforts with DHA and with our service consultants to figure out ways to get to the left of boom. And so we're looking at the PHA, periodic health assessment, that's done once a year to make sure that's integrated well into that. We are also looking at how do we deal with this not only in a postpartum setting, but in well woman, which not only affects our service members, but of course our family members as well. So work is happening out there. I also wanted to mention that in the Army's effort through the Holistic Health and Fitness Program, we had a couple of our physical therapists who are specialized in pelvic floor physical therapy provide an education session where we had over 200 attendees. And that holistic health and fitness model is designed at the brigade level, embedded, where we have all sorts of specialists available to support soldiers. And that's in the process of rollout across the Army. So it'll be years in the making, but there's lots of different touch points that we're working on with pelvic floor. So I just wanted to share that with you.
Thank you very much. And that concludes our panel session. I'd like to thank all the speakers for their superb contribution. Thank you very much.